If you look at the literature, you're gonna find so many different terms to define the bone marrow edema. I just highlighted some of them because they are strictly related to clinical future. So someone call it transient osteoporosis, regional migratory osteoporosis, transient, migratory, but let's try to look deeper into bone marrow edema. So probably it can be helpful if we understand the etiology. And some of this etiology is pretty clear, but some other remain totally unclear. We can mainly classify 3 different types of marrow edema. The easiest one, probably the mechanical one, the one as an example related to an ACL injury, an acute ACL injury. We know we're going to find some bone marrow lesion around it. Related to trauma or fracture, bone contusion, that's pretty easy to understand, but it becomes a little bit more difficult to understand when it comes to spontaneous osteonecrosis of the knee, insufficiency fracture, osteonecrosis. So the underlying etiology could be an ischemic one. Another easy bone marrow edema, easy to understand at least, is the reactive one that can be linked to infection, tumor, or inflammatory osteoarthritis. So many different causes. We try to categorize in 3 main groups. And to simplify as much as possible the etiological pathway. Basically, we got the normal bone. This bone received a kind of injury, vascular, mechanical, traumatic, inflammatory, or whatever, and there are also discussion if it starts from the articular part, so from the joint into the bone, or from the bone to outside, so from the bone to the joint. And what happens, that's the turnover of the bone is compromised, we have an increase of intraosseous pressure, and this increase of intraosseous pressure reduces the vitality of this bone, basically. What's really important is the end of this process. So we have 2 different pathways. It can resolve, sometimes even spontaneously, or it can lead to a bone necrosis, and that's why we need to do something for it. But let's take a look to clinical future. Of course, we're going to focus on spontaneous osteonecrosis or post-arthroscopic one. So the question is always, it was the arthroscopy the main trigger for the bone edema, or on the opposite, the bone edema was about to come and then I did the arthroscopy, so they are not related, but maybe they are related with the meniscal injury itself. So let's try to see if there are any differences from a clinical standpoint. We can say that usually middle-aged people are much involved. So for the spontaneous osteonecrosis, according to the literature, is older than 50 years old, younger for secondary osteonecrosis. Female in the spontaneous osteonecrosis could be more involved than male. Most important clinical feature, you got an acute pain that usually worse at 9, so it's not related to weight bearing most of the time. And what about the imaging? The imaging is even more complicated because usually you ask for an MRI, you ask for an X-ray. The X-ray is totally normal in the early stage. You're going to see the effects of the bone edema if the bone collapses and it becomes osteonecrosis, so only in the late stages. But X-ray, of course, is always useful for differential diagnosis. Recent study also suggests to use dual energy CT scan, which use calcium subtraction from cancellous bone. It appears to be really accurate in post-traumatic bone edema. Diagnostic performance is lower when you have a spontaneous osteonecrosis, but for sure is an option when patient cannot undergo an MRI, maybe for metal artifacts or general situation. Gold standard remains the MRI. So the MRI is pretty easy, as you can see. If you look at T1 session, you'll see the bone marrow lesion like a dark spot. If you look for proton density, T2 fat suppressed or steer, you're going to see the bone marrow lesion very bright. There are different MRI scoring systems to describe where the lesion is located, how big it is, and in a certain sense, it would be helpful for deciding the treatment, but none of this classification is very useful or very easy to use. When it comes to treatments, for sure, main things we're going to look at location, size, and somewhat called the ARCO stage. Basically, in the first stage, 1 to 2 stage, you're going to see only the edema. In the third stage, you're going to have the insufficiency fracture, or it will start to collapse, so it will start to be visible also by looking at X-ray. And in the fourth stage, it's kind of impossible to distinguish, to differentiate it with an osteoarthritis, because you just got joint space narrowing and the collapse of the bone. This is an interesting study from Mayo Clinic, actually. They try to understand when you got insufficiency fracture, which one of them are going to progress to the necessity of an arthroplasty. And they found different fissures. So Kellgren-Rollins grade 4, it means that you already have an osteoarthritis. If the osteonecrosis, the bone edema, enters the medial femoral condyle, and if there are any meniscal tear or extrusion. And they try to figure out the score and dividing into low, medium, and high risk to suggest when it's better to start thinking to an arthroplasty from the beginning. But let's go step by step. So when you have small bone marrow edema and at the beginning, ARCO stage 1 to 2, of course you can try with the conservative treatments. Mainstay of the conservative treatment, no or partial weight bearing and use of anti-inflammatory drugs. Of course, they have limited effects. But first line option usually are bisphosphonates, denosumab, vitamin D have been explored recently, because if the bone marrow edema is a kind of transient osteoporosis, for sure the cycle vitamin D is also included in that, and so that could be something that helps in the treatment of this lesion. Prostacyclin and physical modalities. Let's see the most used one. For sure, bisphosphonates are first line option. They basically inhibit the osteoclast and bone resorption, so just try to implement the osteoblast. Clinical studies show good improvements. Different drugs have been tested: pamindronate, andronate, ibandronate, and zoledronate, with or without vitamin D. The most effective, it appears to be the renindronate, but the truth is, we don't know the optimal dosage and duration. So nerindronate was first used intravenous. Now you can do it like intramuscular injection, but we do not really have a real algorithm for treatment with them. The itoprost, the prostacyclin, were also proposed with good clinical results, but apparently side effect was a little bit higher, general side effect, and so they are not very used anymore in clinical practice. What about physical modalities? Mainly pulse electromagnetic field and extracorporeal shock waves therapy. Recent study all are talking again about hyperbaric oxygen therapy to treat this lesion. What's the mechanism of action of the electromagnetic field? They reduce inflammation, promote bone healing, reduce free radicals, increase osteogenic activities, plus their local, safe, and non-invasive treatments. What about the extracorporeal shock wave? Basically, they are supposed to increase the neoangiogenesis, the osteogenesis, and pain control. Some studies try to combine the effect of biphosphonate and the use of shock waves. But most of the time, we are talking about small case series rather than randomized clinical trial. What about the surgical treatment? Surgical treatment is, of course, the second option, or it could be considered as first-line option when you have very large lesion, or when you find the lesion in a pre-collapse or post-collapse stage. I'm not going to talk about replacement, but I'm going to focus my attention on cardiac compression, subchondroplasty, and high tibial osteotomy, so in the pre-collapse stage, since the topic was bone marrow edema. What's the core decompression? Ideally, it works because if we say that at the base of this pathology we got an increased intramedullary pressure, if we drill the core area, this will reduce the intraosseous pressure and increase the blood supply, and so help the bone edema to be solved. Several studies try to combine core decompression, autologous bone graft, electromagnetic fields, and so on. The subchondroplastic, quite similar but different, because you basically inject calcium phosphate as a bone filler into the lesion. Apparently it stabilized the focal symptomatic marrow lesion. Clinical results were promising. Usually poor prognostic factor are age, and of course when you already have a sort of osteoarthritis. Main advantages of core decompression or subchondroplasty is there are very simple technique with low morbidity, but from a technical standpoint they can be a little bit challenged because you cannot see with the fluoroscope the lesion, so especially if you are treating a small lesion, it's not so easy to be at the center of the lesion, but potentially you can incorporate any bioactive agents. Recently, bone marrow aspirate concentrates have been explored in association with the subchondroplasty. What do I do to improve the accuracy when I use the subchondroplasty? I choose a pretty big lesion in this case, but it's the same. If I look at the X-ray is completely normal actually in this patient. So what I do an MRI first, and then I reconstruct three-dimensionally the MRI, and I print basically some PSI guide that allow me to arrive with my needle into the center of the lesion and to inject my BMAC by my bone marrow aspirate. Actually, I do the aspiration from the needle itself, from the knee itself. Then I centrifugate the blood, and then I use this kind of a very, very easy printed guide. As you can see, is stabilized through the patella and the tuberosity, and then I only have the perfect point where to inject my bone marrow aspirate, so I don't even need the fluoroscopy intraoperatively. And these are the results at 3 months. It was the same case, the same picture I showed you at the beginning. So patient is doing very well, and there is no sign of bone edema anymore. HCO, of course, they remain a valid alternative when you have when you need to correct a mild varus deformity and to unload the medial femoral condyle. And it can be used with or without any cartilage procedure according to the cartilage defect. So microfracture for small lesion, you can use machioramic for medium size, or even osteochondral autograft or allografts. In conclusion, we still lack clear and universal terminology, and probably also etiology is not so clear, but for sure MRI remains the gold standard when you have a doubt, when you have this patient with a normal X-ray but a huge pain that works at night and is not related to weight bearing. Always ask for an MRI, because maybe this could be the solution. Conservative treatment is always the first line treatment. I usually start with no partial weight bearing, also the electromagnetic fields and the biphosphonate. But if I have to go to a surgical option, this will be my choice. So BMAC subchondroplasty with 3D printed guides. In conclusion, before saying you thank you, I'm honored to be the scientific co-chair of the next ESCA meeting that will be held in Milan in 2024. So please submit your abstract. Abstract deadline is in mid-September, so don't miss this opportunity to come to Italy. And the second event I want to invite you, I'm also honored to be the co-chair of the next SIAGASCOT meeting in 2025. It will be held in the south of Italy, in Napoli, and I hope you can join us there. Thank you very much.